This slide shows you a few of the course abbreviations we'll be using. Some are used throughout psychology, whereas others we're just going to use in this particular course. Psychology symbol, the psi, the first one. I've introduced my intro psychology students. It'll be useful for us too. It's much shorter than the word psychology, obviously, or much shorter than even PSYCH. Next, we're going to use MI as abbreviation for mental illness. That's more or less specific to this course, as we'll use D for disorder. RX for treatment is a standardized symbol. Next time you get a prescription, if it's a paper prescription, look on the pad and you will see RX for treatment. And we'll be using SJS for subjects. It's, again, course specific. If you use these, it'll help you keep up with your peers as you take notes or as you take notes on the slides if you're doing this course separately online. The focus of abnormal psychology are the mental disorders, but the term mental disorder can be said in various ways. Mental disorder is obviously acceptable. It can be used interchangeably with mental illness. It can also be used interchangeably with psychological disorders, or it can be used interchangeably with psychological illness. So no one is necessarily strongly preferred over the others. Certain authors or teachers will prefer one or the other, but still treat them all interchangeably. Since the focus of our course is abnormal psychology, it's essential that we learn the definition. I have blanks in the definition, so I'd like you to try to determine on your own, if you can, what should go in there. We'll define it as the branch of psychology which attempts to something, something, and something, something in the topic of the blank blanks. For a hint, you can see that the first 4 blanks should be the goals of psychology, and the last 2, the focus of our course. The first blank, be on the D, if that's a help. Is it define, determine, describe? Hopefully you're going to go with the word describe. Second one could be explain or understand. Third one, predict or prediction. And the fourth one, control, change, modify, help. And the last 2, well, mental disorders, mental illnesses, psychological disorders, or psychological illnesses. If you're trying to figure out the noise, that's Bailey, my foster dog. You come to visit. He says hello. As you read the definition for a psychological disorder, try to fill in the 3 blanks. Given the previous slide, I think it'll be pretty easy for you to do. But as you consider the definition, focus on the term health condition. Many people, of course, including students, think of psychological disorders as one category in their mind and physical conditions another category. And I would urge you, for the good of yourself and society and your family, put them all in one big category. So virtually every psychological condition has physical components and vice versa. So maybe you would have in the past said, oh, physical conditions, diabetes, heart disease, psychological conditions, anxiety disorders, mood disorders. Instead, place them in one big category. This will help to remove the stigma that's in the previous generations associated with mental health conditions. If a person is willing to admit that they have a mental health condition, they're more likely to get it treated, which will have a profoundly positive effect on them and all the media people around them, and even greater society. So again, focus on the term health condition. In terms of the blanks, I assume that you're very tempted correctly to say think, or a good synonym such as cognition, act, or a good synonym such as react or behave, and feel or emotions is the last one. Let's consider the indicators of abnormality, the 4 Ds. First one is danger. That would refer to danger to self as well as others. That being said, it is a misconception that mentally ill people as a group are dangerous. Most crimes are committed by people that are legally sane. Statistics clearly show us that the mentally ill person is not more likely to commit violent crimes. They are much more likely to be a victim of crime, but again, they're actually less likely to be the committer of a violent crime. Deviance, that refers to violation of social norms. Distress, it refers to personal distress. Feeling bad, feeling negative emotions, suffering. Dysfunction, inability to meet life's basic demands of self-care, of working, of maybe going to school, of taking care of the others in your life, such as children or elderly adults. So inability to meet the daily demands that we all face. So consider the women shown in these slides. The neck stretching rings, which actually don't affect the neck but really push down the shoulders, or the bound feet of China. These behaviors have to be regarded in the social context, so if this person is living in their culture, it would not be considered to be abnormality. Choosing these behaviors while living in America would, in contrast, definitely be a deviation from social norms. So the 4Ds are one way of looking at psychopathology. An alternative criteria is the one on this slide. Now you'll see some of the items directly correspond to the other slide. Others can definitely be related, but they're not direct. So before you listen to the narration, if you could, go to the two blanks and see what term I'm fishing for, and then you can listen to the narration. I'll try to be brief for you. So the first one, deviation from social norms, got its own slide, just one slide before, so let's skip to number 2, behavior rarity. Now this is not necessarily a good rarity or a bad rarity. Being a genius is a rarity. Being intellectually disabled is a rarity. So this one could be either good or bad depending on the particular issue at hand. Personal distress, that relates very nicely to the previous slide. So if you can think of some, let's take a moment and maybe think of a few health conditions that jump out at you first in terms of which the person is personally distressed. So actually take a moment, maybe think of 3 or 4. Actually do it, please. Anxiety disorders, mood disorders like depression, some of the somatoform disorders, substance abuse may or may not, a whole list of them. But we should note that not every person with a diagnosable disorder is distressed. A person with maybe ADHD, a young person, might drive their teachers and bus driver and schoolmates and parents to wit's end, but they may or may not be feeling distressed themselves. Maladaptive behavior, doing behaviors not in your best interest. Being habitually late to class is not in your best interest. Doing half the quizzes and doing a half effort, not in your best interest, and so on. Taking it up a notch, perhaps the same continuum, perhaps not dangerous to self and others. Kind of self-explanatory, I believe. Next, severe disorientation. Maybe for this one, picture a person with Alzheimer's, but it could be many mental disorders, including schizophrenia perhaps, and many others. So, but let's picture the person with Alzheimer's. The 3 W's. Take a guess. Can you figure out any of the W's? I'll give you a moment. They might not know who they are. They might not know where they are. And they might not know when they are. They might think it's back in the late 70s and perhaps a different president was in charge. Jimmy Carter, perhaps. Obviously, false belief, a nice short definition for delusion. False perception, a nice short definition for hallucination. Severely impaired functioning, so the person may not be able to maintain themselves in a healthy and safe manner. So to be able to do their hygiene, safety, if they're impaired, how to access services that they need, and so on. So think of this as an alternate criteria for our 4Ds. Throughout the bulk of human history, humans explain mental illness and even most physical illnesses in terms of demonological model, that is, being caused by supernatural forces. And it would make sense then if you thought that the supernatural would be the cause of physical and mental disorders, then it would have to be central to the treatment of physical and mental disorders. So if that makes sense, let's look at a few of the treatments associated with the demonological model. This is an example of a skull that's been trephined. You can see the word trephine or trephinization or trephining. It refers not to the drilling, but rather the cutting of a hole in the skull, presumably to release the supernatural forces. This person had the jackpot. You'll see in the frontal facing skull, 2 holes, and the backward facing one. If you look closely, you'll see at least 5 holes. Did people survive this procedure? Definitely. People who know bones can look at the edge of that bone and tell whether the person survived it or not based on some signs of healing. And indeed, this was very much a survivable procedure. Many students get confused and think the brain is being touched. The brain is not being touched. Underneath the skull would be the protection for the brain. Do you remember the name of the protection? Think about it for a moment. Was it blood-brain barrier? Was it myelin? Was it meninges? It was the meninges. So the scalp would be cut. The piece of skull would be removed. Who knows what they would do with it? The person would be sutured back up. All done, of course, without local anesthesia because this is ancient times. A slight bump in the head with the skull missing would be lethal. Did this cure mental illness? Presumably not. It would be a fair assumption to say that not only they had whatever mental illness they originally had, presumably schizophrenia, but on top of that, they would almost always, I would assume, have a good case of PTSD. One might wonder, well, why can't the supernatural forces exit the same way they entered? My answer is, perhaps, think of a lobster trap. The lobster can get in, but it can't get out. So maybe these holes, these exits, you want to be fancy, these egresses were made to facilitate the leaving of the mental illness causing spirit. Now, if you would go back to our previous slide so we can consider the more modern technique of lobotomy. The 2 major treatments associated with the demonological model would be exorcism and trephining. Now, exorcism would vary quite a bit from culture to culture, from time period to time period, but exorcism always involved rituals designed to drive out the supernatural forces. If you were lucky, it might be praying and chanting. Certainly would do you no harm and quite possibly some good. But in other societies, it might be submersion in cold water, forcing the person to have emetics, things that would cause them to vomit, any binding, anything that would make the physical body so terribly uncomfortable that the spirits would be motivated to leave. So it could be very akin to torture in some circumstances. Do societies still engage in exorcism? Absolutely, positively. Even, for example, the Catholic Church, on very special occasions, will receive a discompensation to allow its use. So your HMO will not pay for it, but it's a part of many, many cultures and many people's belief systems, even to this day. So let's consider the contribution to Hippocrates to abnormal psychology. Time period about 460 to almost 400 before the present. No, you do not need to know that date. Just want to give you a kind of a picture of time period. I often ask my students in terms of background information, what do you know about Hippocrates? So Take a moment, and do you have any associations with Hippocrates? Some students say Hippocratic oath, excellent, or oh, don't be a hypocrite, often also excellent. And he's often considered to be the father of Western medicine anyway. Now, in terms of his view of mental illness, a rather modern view in some ways. He thought that illnesses had both a physical and psychological component. For example, in some situations, he would prescribe for the person to get away from their family, recognize for some people the family could be a contributor. So again, seeing mental illnesses as having physical and psychological components. So now let's consider a time period which goes by many names: medieval times, Dark Ages, Middle Ages. During this time period, Rome and the rest of Europe fell into an economic, intellectual, and cultural decline. Fear and suspicion and ignorance became the rule. This lasted from about 5th to 14th centuries, almost 1,000 years, and no, you don't need to study that date for me. So where do we stand in terms of their view of mental illness? Well, far from being the way Hippocrates viewed it, we slid back into a firm belief of the demonological model. So all the gains that had been incurred in thinking were lost. So as we saw on the previous slide, the Middle Ages, Dark Ages / medieval time period ended with the arrival of the Renaissance. Renaissance, 13th to 17th century, and again, no, you don't need to know those dates for me. Perhaps for your history teacher, but not for me. So this was a time that we came back into more modern thinking, great advances in art, building construction, medicine somewhat, moving forward. And yet, we did not see, in many ways, this carry over into the treatment of the mentally ill. So this was a time period of both forward thinking, and in both Europe and America, fear of witches and witchcraft, and the persecution of witches and witchcraft. On the next slide, we'll see how this relates to our course. So let's compare witches and witchcraft in Europe versus the colonies. In the colonies, 19 people were killed, and you might assume that they were burned. Thank goodness, no, they were hung. Estimates for approximately 100,000 men, women, and children were killed with the charge of witchcraft. Who were the identity? Quite variable. Some were women that had power, so women in power were not acceptable by the establishment. This was a good time to eliminate them. It could be somebody who just had something you wanted. Maybe there was a good pond on their land. If they were out of the picture, you would have that pond for your livestock. It could be just people that were rude or offensive, but particularly, and related to this course, people that were mentally ill. So many people that behaved bizarrely, particularly people with schizophrenia, were much more likely to be charged and perhaps executed as witches. So in this time period, even though it was the Renaissance, extraordinarily backwards. Yet at the same time, asylums were starting to be built in the European era, and these asylums were originally just buildings that were left over. Vacant buildings, for example, leprosariums, old leper buildings that no one else wanted to use. And these empty buildings became a place where we could store the mentally ill away from society. Visit the link and you'll see asylums in America, what they look like now. These would be the old abandoned ones. I picked out this particular source very chilling, and I will show you a few other pictures later on in this chapter of it. So do take a visit to this link. Let's now consider the reform movement for abnormal psychology. Time period, think of the time period roughly around the time of the Revolutionary War in our country, in the time period leading up to it. So about the 1770s through just getting into the very, very early 1900s. During this time period, instead of the traditional inhumane treatment that had been the norm, the focus was now something called moral treatment and moral therapy. At the heart of this moral therapy was the humane treatment of the mentally ill. It flourished until the late 1800s, at which point it started to rapidly decline. Why the decline? In part due to lack of money, which caused the wonderful facilities that were built to become neglected and overcrowded. And staffing became very poor quality and often abusive. Another reason for the decline was the dislike of the mentally ill. Many of them were immigrants suffering from the extreme hardships of leaving their own country and their maltreatment in the U.S. So, due to prejudice against immigrants and the perception that the mentally ill were dangerous, and as we will learn in this course, an incorrect presumption. We'll look at some of the key players in the subsequent slides. They include the reformers of Italy, France, England, and 3 American reformers. The picture that you will see on this slide or the next slide was for the state lunatic asylum in Utica, and that was the correct terminology of the day and time. They would have sometimes dances for the peoples at the institutions, and they were often termed lunatic balls. So again, obviously reflecting a terminology not acceptable to us, but acceptable back then. Next, we're going to consider the rock stars of the reform movement, the who's who's, if you will. If I was teaching it live in class, I would ask my students who could actually pronounce names well to do it for me, but you're going to have to suffer through my pronunciations. So, Vincenzo Chirughi, the Italian reformer. Jean Baptiste Poussin, a French reformer. His colleague, Philippe Pinel. And the Americans, Benjamin Rush, Dorothea Dix, and Clifford Beers. Now, by the time you're done with these slides on these reformers, you should know the ins and outs of what they did to improve the world, and hopefully also, as per the bottom of the slide, be able to identify who was the most important reformer of them all and why he or she is considered such. Let's start with the reformer of Italy, Vincenzo Chirughi, who had a very odd combination of both barbaric treatment and moral therapy. His humane practices, including allowing the patients to bathe and encouraging bathing and hygiene, separation of men and women to protect the women from sexual assault, gave access to the grounds, had exercise. Now, in terms of details about his particular experiences, he was the director of the Bonifacio, if I'm saying it correctly, hospital in the 1780s in Italy. If you just know that he was a director of a hospital, that's more than enough to keep your teacher happy. What about some of the barbaric practices that would not be considered to be moral therapy? Using heat to blister patients, purging, in other words, causing forced vomiting, bleeding, a popular and sometimes lethal therapy of the day, cold, icy water baths, dunking people, so fear of drowning is while they're also being exposed to the cold water. And he also believed in whipping his arrogant patients. So again, a very odd blend of moral treatment and barbarism. When I Googled Jean-Baptiste Poussin, this is what came up. Somehow I don't think this is necessarily the image for our class. Poussin was one of the two great French reformers. He worked with Pinel and actually was one of the two founders of the moral therapy movement. He was the superintendent of a particular hospital in France, the mental ward that is, of Le Victory. And we should know that he was a superintendent, meaning that he was in charge of the day-to-day runnings of this particular institution. Of all the reformers, both American and European, Philippe Pinel is by far to be considered the most important. He was drawn to this area due to a friend's suicide. He wrote very influential texts, and you don't need to know the name of it, but I would like you to know he wrote a very influential text. He worked with Poussin at Le Victory, that we mentioned before. He had daily conversation with his patients and created case studies. Again, he was using the scientific method. And for these reasons and more, he was considered to be the most important of all the reformers. In this famous painting, it showed Philip Pinel unchaining the patients, which is definitely a bit of artistic liberty, since it was not Pinel that did this, but Jean-Baptiste Poussin, who we learned about on the previous slide. Even back then, there was a little bit of fake news. Let's next consider Samuel Tuke, the great reformer of England. He was a Quaker abolitionist. He became drawn to the area when visiting a local mental institution. He saw female patients naked chained to the walls. He was motivated to secure funding and build his own institution, pictured on the slide, on 11 acres. The buildings themselves were spacious and airy. He abandoned the current practice of bleeding patients in favor of giving warm baths, and encouraged the individuals institutionalized to fill their activities with productive labor, such as sewing or knitting. So certainly a drastic improvement from the prevailing facilities of that day and age. Let's next consider the American reformers, starting with Benjamin Rush. Perhaps if you take American history, his name will come up. He was one of the founding fathers, being both a member of the Continental Congress and a signer of the Declaration of Independence. He was a Surgeon General for the U.S. as well as a U.S. Treasurer. He founded Dickerson College, if you're familiar with it, and I don't know if this is good or bad for you people who have taken chemistry. He wrote the first American chemistry textbook ever. He was also an abolitionist and had other bizarre ideas. Not only was he an abolitionist, if you want to believe it, he believed in the education of women. He also believed in free medical clinics for the poor, so basically socialized medicine. Unfortunately, as a doctor, he thought bleeding was helpful for just about every condition. He thought that mental illness was sometimes caused by the overexcitation and irritation of blood cells, so we would lock patients in that device shown on the bottom, his chair, for hours at a time. He's also reputed to believe in a kind of scared into sanity approach in which, reputedly again, he would put people at the bottom of a well tied up and put water in it, making them fear of drowning. It's unclear if he actually did this, but that appears in some writings. But anyway, a very unusual combination of extremely progressive and humane and dysfunctional and harmful. We can't leave Rush without mentioning another bizarre belief. He thought that people of color were basically the same as white people. It's just that they had a particular skin condition which could be treated if they found the right treatment, and they could become white people. So although the idea of potential equality in that day and age was nice, the bizarreness of it and how you got there, obviously lacking. I should quickly mention that occasionally I see on TV an ad for a Benjamin Rush Center. Don't worry, they're perfectly modern. There is no spinning, there are no chairs, there are no bloodletting, but his therapy treatment of humane and cutting edge, literally, pun intended, treatments still remain. The next American that we'll consider will be Dorothea Dix. She was a Boston school teacher, and she wanted to help the mentally ill. She went to prisons to read Bible to them, but she found that the Bible was the least of their needs. She was horrified by the conditions that she saw. So she traveled from state to state, seeing the conditions firsthand, and also lobbying the state legislatures and Congress for funds. She spent over 40 years of her life. Remember, back then, the average person died at age 50, by the way. So she spent 40 years of her life from about 1841 to 1881 fundraising and lobbying. The funds directly contributed to the building of 32 mental institutions, which were state-of-the-art. And also from her work, each state was charged to build public hospitals for the mentally ill. The last American that we'll consider will be Clifford Beers, quite different from all the other reformers. He himself suffered from mental illness, and he and his 5 siblings all died in mental hospitals. He wrote a very influential book about his experiences, A Mind That Found Itself, published in 1907. He was forced to sleep in a straitjacket so tightened that it cut off the circulation of his hands. He spent days in bare, unheated cells, clothed in only underwear, and commonly witnessed the beating of patients, in his own words, so far out of their minds that they could not comprehend or obey orders. And so through his book, people learned of the experiences, felt great sympathy, and he had a significant impact in the treatment of mentally ill in our country and how they were regarded in this country. Let's now consider some of the many advances in the care and treatment of the mentally ill from about the mid-1800s until the present. Let's consider the concept of warehousing. Before we had effective treatments for mental illness, if you suffered from a severe mental illness, you were put into an asylum or other institution, and you often spent your entire life there. You would typically be abandoned by your family. You would typically die there and be buried on the grounds, so no escape, even in death. When did this end? Well, when we saw the advent of effective psychiatric drugs. The lobotomy was a technique we'll discuss in a few slides below. I should mention that one of the promoters of lobotomy, Hist, he was Portuguese, received the Nobel Prize for his particular use of the procedure, as well as being shot by one of his patients, resulting in paralysis. You might call that a mixed review. ECT, we'll be discussing this in a slide or two. Neurotransmitters, we had a vast increase in neurotransmitters leading up to the introduction of psychiatric drugs beginning 1950 and the few years beyond it. So now, for the first time, we were having effective treatments for depression, bipolar disorder, and schizophrenia. Deinstitutionalization refers to the mass release of the mentally ill from institutions due to the effectiveness of psychiatric drugs, and many of these individuals have been institutionalized for years or decades. And this began starting in about the mid-1950s. Next thing we should consider was something called the Community Mental Health Center Act that was in 1963. It mandated all states and major cities to make provision for the mentally ill that were now deinstitutionalized, providing outpatient services, as well as other people in the community that would need these same mental health services. So you might notice a considerable lag between deinstitutionalization, mid-50s, and this act, 1963. In terms of technologies, we'll talk about such things as EEG, VNS, DBS, TMS. Next, we'll consider the fact that big business HMOs now exert considerable control over therapy. And this became problematic because they decided that there should be a difference in funding between psychological illness and mental illness. This differential treatment was outlawed in 2018 in a group of laws called the parity laws, which mandated that equal spending should be for both physical and mental illness. So if your plan had so many days for a physical illness of hospitalization, had to be same for mental illness. If you could spend this much on drugs for a physical illness, they had to spend the same amount for drugs for a psychological illness. But even then, since then, there have been many lawsuits where HMOs were not providing the parity that was required by law. Let's now consider the lobotomy, sometimes called the ice pick lobotomy because of the technique which is used, shown in the picture on the right. Its precursor was first developed by Hist, a Portuguese physician, in the 1930s. He eventually earned the Nobel Prize for it, and people have lobbied basically since then to have him posthumously stripped of the Nobel Prize. One of his patients shot him and he became paralyzed. I guess in theater they would call that a mixed review, but that's how it began, and it's continued in its notoriety. Walter Freeman was the American proponent of it. He lectured, he endorsed it, probably the reason why lobotomies continued for well over a decade in the U.S. compared to other countries, even compared to Russia. Walter Freeman would do the procedure in about 10 minutes. He could do as many as 25 in a day, rather like an assembly line procedure. He was eventually stripped of his medical degree when one of his patients died on the table, and he just, being filmed, he just had the next one wheeled in. So that was enough. Let's see, he did about 3,500 in his lifetime. In terms of the number done in the U.S., estimates vary around 50,000. On the bottom, you can see a picture of a very famous movie on the topic, One Flew Over the Cuckoo's Nest by a very young Jack Nicholson. You can see Walter Freeman in his procedure, and next to it you can see a picture of Hist. Possible outcomes included epilepsy. That was the most common outcome. Also emotional, they could call blunting or apathy, lack of motivation. Some patients did suffer from enuresis or encopresis, lack of bowel or bladder control, and some suffered from long-term headaches. Were they improved? Well, they were more manageable. They were passive. Were they actually better? Very few. Probably some, but very few. But they were controllable, and I think that was the key. When did it stop? Very gradually fell out of favor by the 1970s early point. They were gradually just replaced by the medications. We learned about these psychotropic drugs, so their use was no longer necessary. So a lot of history. Hope you get out of that. You might have to listen to it twice. Let's now consider the two major 20th century approaches to the understanding and treatment of mental illness. Again, remembering the bulk of human history, the demonological was the preferred and virtually only model. First, let's consider psychogenic perspective and then somatogenic. The psychogenic, and make sure you don't put genetic by accident if you're asked to provide the term psychogenic, the viewpoint that mental illness is caused by psychological factors such as stressors. Championed by Mesmer, who mesmerized audiences for both entertainment and a little bit of treatment applications, but primarily he was an entertainer. He wore a flowing purple cape, and he had a purple turban, and he had a mystical rod, and he would entertain the rich and or nobility of his day and age. In Intro Psych, I mentioned that the King of France could not decide whether Mesmer was a scientist or a charlatan. He charged not one, but two different commissions to investigate him, one headed by Benjamin Franklin, who concluded that he was a charlatan and fraud, amongst other things. But after Mesmer's death, different physicians started to look at the possible use for treatment of mental illness. Two physicians whose names you do not need to know, members of the Nancy School, named after the town Nancy in France, used it to treat mental illness. They also showed that it could produce mental illness-like symptoms. Next, Breuer, whose name you might not know, Joseph Breuer worked with Freud, and indeed, Freud's famous patient, Anne O, Freud never treated. Freud was actually working with the notes and the help of Joseph Breuer in describing with Anne O. Next, let's consider the somatogenic, and be careful, not genetic, but genic perspective. Many texts and teachers prefer the term biogenic, but your textbook prefers somatogenic. Now, if you had me for Intro Psych, you probably learned that the cell body of a neuron is called the soma. So if you remember soma means body, then somatogenic would be, somatogenic would refer to body. So in this approach, there's an emphasis on the physical causes of mental illness. It was championed by Emil Kraepelin, who wrote the first classification system for mental illness. If you spell classification with a K, it might help you to remember that's associated with Kraepelin. It was also championed by von Krafft-Ebing, and he showed that mental illness, in the case of the condition of genital paresis, had a physical cause, that of syphilis. So here was the first evidence ever that a mental illness could be caused by a physical disease. So we're going to begin our discussion of the major 20th century approaches to treatment of mental illness with the big players. Top right, we see Emil Kraepelin. Below that, we're going to see von Krafft-Ebing. Below that, we're going to see Anna O. And next over, showing the partnership and collaboration between Joseph Breuer and, of course, Sigmund Freud. So Joseph Breuer saw a patient who became known in the literature as Anna O. She had what Freud later termed hysterical symptoms, in other words, symptoms of hysteria, including partial paralysis and blurred vision, plus also many other symptoms that didn't go with hysteria, such as hallucinations and mood swings and headaches. Later thought that she might have had TB that was impacting her brain, but in any case, symptoms of hysteria. So Joseph Breuer noted that when talking to her and the use of hypnosis, the symptoms seemed to fade. So this became the birth of the talking therapy, or the talking cure. In other words, psychotherapy. And later on, Freud and Breuer collaborated in the famous book on hysteria. It should be noted that, again, Freud never worked with her directly. Now, Anna O, whose real name we now know as Bertha Pappenheim, she thought that she got better in spite of their his treatment, that is Breuer's treatment, instead of because of it. She became rather a force, and she was one of the founding mothers of social work in Germany, amongst other treatments. And again, from her perspective, despite rather than because of. So an interesting history, to say the least. Let's now consider ECT. First, take a moment and see if you can think what each, or guess what each letter stands for, and whether or not it's still used. And thirdly, and lastly, what condition is it most likely to be used to treat? So again, what do the letters stand for? What is it used to treat? And is it still used currently? So ECT stands for electroconvulsive, make sure there's a V in there, electroconvulsive therapy. It's primarily used to treat major depression, though is sometimes used to treat bipolar disorder or even schizophrenia. It is still used, and it's still considered to be the best choice for major depression, which proves to be highly resistant to any other form of treatment. Under those conditions, where virtually every therapy has been tried unsuccessfully, ECT will work in about 80% of the cases. It's not given in one treatment, it's given in a series of usually 6 to 9 times over a period of weeks. And it, again, usually is effective. Nowadays, it's performed differently than the past. The person is anesthetized. Typically, it's performed unilaterally, that is only in one hemisphere. It was first discovered, if you will, by Italian Ugo Cerletti in 1937. And next, if you could go into the link, you'll see a little bit more information on modern ECT. So let's now consider the modern mental health professionals. The rarest by far would be the psychiatrists. Look at the time spent in college and medical school and residency and internship. But the psychiatrist went to medical school and is a medical doctor, an MD, who has had further specialization in the area of psychiatry. And they can do things like write prescriptions in all states and order procedures like TMS or ECT, what have you. The clinical psychologist is a PhD. You still address them as doctor, but they're a PhD. You can see their average length of training. The counselor often has a master's, but might have a PhD, less trained, not meaning less good, but just less specialization. Social workers are the most common mental health professional and work in so many settings, from high schools to their agencies to in their own private practice or in other practices. If you want to be a social worker, you would start your journey at SCCC in the Human Services program and then go on to a 4-year college for a social work program. But to do training, you would need a master. To do therapy, you need a master's. Counselors would be, and clinical psychiatrists would be at our college in the psychology program in the liberal arts division, and will go on to be a psych major down the road. The psychiatrist would be in the math, science, or science program and would be medical school bound.